I want to welcome you to the first episode of Beyond Talk Therapy, What Actually Heals Trauma. My name is Elisa Fernandez. I'm a clinical social worker and psychotherapist with over 23 years of experience. I'm also the founder and clinical director of a trauma therapy center in Toronto that focuses on healing from trauma and attachment wounds. It is with great pleasure that I introduce you to a conversation I had with the creator of Deep Brain Reorienting, Dr. Frank Corrigan. Dr. Corrigan is a psychiatrist from Scotland with decades of experience in trauma and dissociation. He will talk about the origins of Deep Brain Reorienting, what led him to create this modality, and some of the nuances and what to expect in therapy, and also talk about the future vision he has for Deep Brain Reorienting. Deep brain reorienting is a subcortical modality that really focuses on how we orient towards threat and how our brain body holds on to the shock and the natural sequence that follows the shock, which includes affect and a defensive response. So if you have felt stuck in talk therapy, if you're a clinician in trauma therapy world, you'll want to listen to this interview. It is with great pleasure that I introduce you to this conversation, his first in-person interview and my first interview as well.
Frank, thank you so much for taking time out of your busy schedule to meet with me and have this conversation and really to let the world know a little bit more about deep brain reorienting. And so I wanted to thank you and get us started, if that's okay.
Thank you for inviting me.
Oh, you're so welcome. So I wanted to ask you a little bit about the clients that inspired you to develop deep brain reorienting.
Yeah, the ones who inspired me were the ones who were most severely traumatized because I found that the existing treatments it wasn't possible to apply them to the really severe trauma disorders because they were overwhelming.
Right.
So there's some great trauma therapies that worked well for people with less severe trauma disorders, but were overwhelming for people with more severe or most severe ones. So
Right.
I was always looking for a way to make it less overwhelming for people to process the horrors of their early life, particularly.
Right. Can you say a little bit more about what you mean by severely traumatized? Because some people that are watching may not know what you mean by the severely traumatized folks. And you said something really important, which is a lot of people have gone through horrifying early life experiences that remain with it in their body, their brain. So if you could just distill that a little bit more, Frank.
Yeah, so it's often people who've had attachment trauma in infancy. They haven't been looked after properly, they've been neglected, they haven't had good attunements from caregivers, and if they then go on to be sexually abused, for example, by multiple perpetrators, often from a very early age, then they have the combination of attachment, hurt or wounding, and severe abuse that leads to the fragmentation of the personality often and other features of post-traumatic stress disorder of the complex type.
Right, right. Great. So can you explain a little bit about what deep brain reorienting actually is? Because it is it's complex and simple.
Yeah.
Right. Yeah. So can you give us an understanding of what deep brain reorienting is?
Yeah. The most important thing I think that's emerged is to do with shock. That if somebody has a horrifying experience, in the first milliseconds of the experience, their brainstem is reacting with shock.
Right.
And that is quickly supplanted by terror, for example, or rage or sadness. or shame. So we have not tended to look for the shock. We've not tended to look for those milliseconds of shock that happen at the beginning of the traumatic experience.
Right. Yeah. And just as you explained that, your head goes back, which is part of what we do in DBR, is look at how we orient. If you can explain a little bit about the sequence that we work through, and how unique that sequence is to healing people that have experienced a lot of trauma.
So the shock sensations, although they're fleeting, are often highly charged. So we look for a shiver, a cold shiver down the spine, or a shudder, or a jolt, or electrical charges through the body, pressure in the head, pressure in the chest, fleeting pressures often. And we focus in on those sensations to give them space and time to dissipate. But the other important thing in DBR is the orienting tension.
Yeah.
And we've found that before the shock, there's always a tension in specific areas of the face or neck in response to the stimulus, in response to the horrifying stimulus. And if we can find that orienting tension before we get into the shock, it gives us an anchor to help to avoid overwhelm.
Right, right. Because what DBR does that is really unique is that it looks at that brainstem and what the superior calachi, locus coeruleus, and PAG, paracaudal gray, if I'm pronouncing it correct. Took me a while to learn those. That they are responsible for. They make very quick decisions around what to do when there is something horrifying or something that is threatening. And can you speak a little bit more about those features, Frank?
If there was a perpetrator coming towards me, for example, it would be picked up by the superior caliculi of my midbrain that there was a looming threat. So there's somebody coming towards me with evil intent. The tension would probably be at the base of the skull because I would be inclined to pull away, but it could also be around the eyes because I don't want to see that, or in the forehead. So if we pick up that orienting tension at the beginning, that's coming before the shock. And the fact that it's there before the trauma reaction gives us an anchor that's before any trauma activation. So if we get that orienting tension, then we've got an anchor, and we can then slow down the shock sensations and allow those to process carefully and slowly.
Right. The key really is to get that anchor, that orienting tension, how someone oriented, like what they did that helped them with the threat or the perpetrator or whatever the stimuli was that was.
But even before that, it's before the defensive response. It's before what would help. It's actually recognizing at the brainstem level something's coming towards me that looks threatening, and that happens. The superior caliculi, it then activates a circuit through the amygdala, the locus coeruleus, and the periaqueductal gray to name the structures in the upper brainstem that we are concerned with.
Right. And for some folks, some therapists that have been doing deep brain reorienting, or seasoned therapists that have been doing it for a while, can you explain a little bit more by slowing down the shock? Because I think sometimes therapists get confused by what does that mean and how do you slow down the shock. And this is going to be another question that I'm going to embed in this, is that sometimes the orienting tension, sometimes the shock can, and the pain can
Yeah,
be intertwined and come in waves.
yeah,
So if you can help us with that a little
yeah.
bit.
So often the the slowing down means picking up the first sensations of the shock. So the pressure behind the eyes or the cold shiver down the spine. And it sounds impossible to do, to ask somebody, can you hold that cold shiver down the spine? But it is possible usually. And
Right.
the slowing down, being with that cold shiver, gives the energy of it a chance to clear. So
Mm.
we're nobody would ever do this spontaneously, I think. So that's why we need the theory, and that's why we say,
Mhm.
look for those shock sensations now. Let's see if we can hold them. Let's see if we can sit
Mhm.
with that cold shiver energy
Right.
and just give it space and time.
Yeah. And you just said something really powerful, which is if you give it space and time, it dissipates
Yeah,
and the body and the brain know to naturally release it.
yeah,
Can you say more about that, Frank?
yeah, because I think DBR is a way of releasing a natural healing process. So
Mm.
something has got stuck, something has got blocked, and for some reason, given identifying the sequence from the orienting tension to the shock allows us to open up the healing sequence to
Mm.
allow it to flow. And as the shock dissipates, just to return to something you said earlier, often we get a sense of underlying pain.
Yeah.
So it may be a pain of aloneness, abandonment, there's nobody to protect me or rescue me, rejection, humiliation, betrayal, injustice. So
Right.
the pain can have different qualities,
Yeah.
but as the shock clears, we often become more aware of that underlying pain. And again, we're not trying to do anything with it except be with it and give it space and time.
Right. Right. And the importance of the therapist being very attuned and present
Yeah,
and not disconnecting when that process is occurring. Because if a client has a lot of, or if someone has a lot of pain of aloneness, they're going to experience
yeah,
the therapist if the therapist goes into shutdown in some way. And so it's really important for a therapist to be attuned and present.
absolutely
Yeah.
essential for the therapist to be here, now, present, grounded, able to be with the
Yeah.
level of pain that's being experienced by the client. And
Right.
the pain is something that we usually want to run from because
Right.
both therapist and client will not feel comfortable with the level of the pain, especially if it comes from very early life. It can be disturbingly intense,
Yeah.
but the therapist has to be prepared
Yeah.
to be with it
Yeah.
and be present with the person who is orienting towards that deep pain.
Yeah, absolutely. And speaking of how we enter into this work with clients, because you talked about the pain and it can be quite intense when there's a significant history of neglect,
Yeah,
abandonment, abuse at a very young age. The beautiful thing about deep brain reorienting is that we don't have to go right to the onset of the abuse or the pain, that we can use a current day trigger or activation point. Can you speak to that, Frank? Because that's really important.
And it's also something that comes from working with the severely traumatized, because some people have such horrific histories that it would be hard to know where to start. So I argue that we start from what will make a difference in the present. So if we use a present day activating stimulus and we process some shock and pain and emotion from that, that will make a difference in the present. So it allows us then to get into that underlying healing process. And once we've used the present day activating stimuli for a while, often what's important from earlier in life will emerge for us to work on.
And deciding on that entry point, which is called activating stimulus. I was like AS, and I was forgetting the S for a second. You have to do the aware self. Can you speak to the aware self and what that means?
The aware self is another important part of DBR that has been found to be important in a number of ways beyond what I originally expected, because I used it as a way of dropping to the deep level of the brain, to the sense of being here now, maybe using the awareness of the Earth's gravity or the distance to the walls of the room, or the position of the limbs, or the head to tail axis of the spinal column, or things like that, to help to get into here-ness and now-ness. But so it's an essential part of the preparation for a DBR session, and it's also a good guide as to whether somebody is ready to process with DBR or not. If they cannot do aware self and be here now, we don't go into trauma processing.
Very crucial, especially for complex cases. A lot of some people really struggle with aware self. They have a really hard time with that. Which leads me to asking about dissociation, Frank, because you have you've really offered a deeper understanding of the different levels of dissociation and how to work with dissociation when it comes to deep brain reorienting. Can you speak to the 3 different kinds that's been identified, and how to work with those?
And it's not an exhaustive classification, but it's a classification that I've found useful clinically. So just with working with people with dissociative disorders, identifying these different kinds of dissociation, and then having a way of understanding it and helping it to process, and that has proved very valuable too.
Yes, absolutely.
So would you like me to go through the...
if you don't mind, because I think that it's valuable information, and it helped me immensely in terms of working with clients that have complex presentations, especially clients that have dissociative disorders. And so yes, please, that would be great.
So the first one described is what I call supracortical dissociation, and because the midbrain has the capacity to turn away from something or to turn towards something, that comes before the cortical decision to do it. I call it supracortical because although it's functionally beneath the cortex, structurally beneath the cortex, it's functionally there first, saying, don't want to look at that.
Right.
Don't want to see that.
Yeah.
So I think that turning away from something intolerable is often what happens with the aloneness pain in infancy neglect, because that pain feels unbearable. it feels intolerable.
Right.
It feels it's never going to end. And the brain has to do something. And so the midbrain, I think, turns away from it and finds other things um, to occupy it. So when we are bringing the attention back to this pain, we need to do it really carefully because we're asking somebody to become aware of something that they as an infant felt was totally unbearable, unending, and it's usually diffuse, it's usually hard to define in the body in specific terms. It's just a really intense feeling of something that you don't want to go near inside. So so a lot of the work is the gradual turning towards that pain, and that may take a long time.
Yeah. Yeah. And there's a lot of shock that's connected to it,
Indeed. Yeah.
I find,
Yeah.
and that
Yeah.
oftentimes we don't get to affect for a number of sessions.
Yeah.
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 So you can be processing layers and layers of shock
Yeah.
and working
Yeah.
with this deep pain for a long
Yeah.
time. It is not a quick fix.
Right. And it's pretty incredible that as infants, babies, and toddlers, that we have this mechanism,
Yeah. Yeah.
right?
Yeah.
And that dissociation saves us
Yeah.
in many ways, and that we have to turn away
Yeah.
from these significant horrors or absence of
Absence
the
of.
love or
Yeah.
presence of a caregiver.
Yeah.
Pretty incredible.
It is. It is.
Yeah.
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 So it was necessary in infancy, so we don't
Right.
disregard it lightly. We help the turning towards slowly and carefully.
Right. Right. Yeah.
And the second kind of dissociation that I classify is the neurochemical, and I hypothesize that when an affect and a basic raw emotion gets really intense, the midbrain has to bring in some cannabinoids to suppress it.
Yeah.
Otherwise, the heart rate would keep going up and up, the blood pressure would keep going up and up, and death would ensue. So we need those cannabinoids to make it plateau, to cap
right.
it. Yeah. Yeah.
Yeah.
And then there's also the opioids that can come in, especially when there's states of submission or compliance or utter despair. The opioids can come in and produce drowsiness and pain relief.
Sleepiness and yeah.
And then we've also got intracortical dissociation. I should have put that one after the supracortical, but that goes with the shock when there's derealization and depersonalization with shock, that the body disappears or half of it disappears, or the face comes away from the skull, or can be all sorts of disturbances of the body awareness and of reality, and that I think of as always shock related.
Yeah. I think you've introduced and given us a beautiful gift in being able to conceptually understand this and also work with it.
Work with it.
Yeah.
It's the important thing, isn't it?
Yeah, absolutely.
Yeah.
And work with it at a deep level, because oftentimes we've worked with it more, if I could say, limbically based with certain modalities. And so it's nice to be able to get into that deep structure and be able to work with it. Yeah.
And the final type of dissociation in this classification is the structural, and that's a term borrowed from Onno van der Hart and colleagues, but I see the structural dissociation as happening when there loops form in the cortex that hold separated or compartmentalized parts of the self,
Mm-hmm.
and they can become relatively independent then.
Mm-hmm.
So with that, we don't ignore them, we acknowledge that they're there, but we keep working at the deeper level as much as possible, always looking for the shock, the pain,
Mm-hmm.
the raw emotion, and working to clear that.
Right, right. And and that is part of the training, which therapists learn, which
Yeah,
is foundational.
yeah.
Yeah.
Hmm.
Can you tell us a little bit about the research? Because it's exciting to hear, because the research really um, speaks to how it works with dissociative clients.
Yeah, and those results aren't published yet, so I can't
Oh,
say
okay.
too
Okay.
much about it. I
Okay.
can only say that the preliminary results of the
Yeah.
randomized controlled trial in
Right.
London, Ontario, showed a benefit in patients with PTSD and complex PTSD, including the dissociative subtype.
Yeah.
And that was initially 23 in the group's um, DBR group waiting list group, but
Mm-hmm.
now the numbers are up to 47 or so, and we
Wonderful.
hope to analyze those results in the next few months and
Okay.
then publish them. But I believe the benefits of DBR are holding up.
Yes,
Yeah,
absolutely. Absolutely. And that study includes fMRIs
yeah,
pre and post
yeah.
treatment in terms of folks being able to receive DBR sessions.
It's a 7 Tesla, which is a powerful functional MRI
Mm-hmm.
imaging, responds to trauma words selected by the patient before 8 sessions of DBR and then after 8 sessions. And the results are huge. The
Oh, wow.
results are, they bear out the hypotheses to a great extent. They bear out the shock activation from the brainstem
Wow.
arousal systems having a major influence,
Hmm.
and that being reversed by DBR.
Wow.
So, as I say, that's just getting into the full
Mm-hmm.
analysis just now for preparation for publication, but it looks overall very supportive of the theory,
Mm-hmm. That's
which is very
wonderful.
reassuring.
Yes,
Yeah,
absolutely.
yeah,
I've heard a little bit about the findings, but
yeah,
I'll keep I'll keep it uh to I won't share it at this point. Yeah, but
yeah,
it's exciting to hear about how the brain, the significant shifts that happen in the brain after they receive the 8 sessions. It's
yeah,
really incredible.
yeah,
Yeah,
yeah, yeah.
yeah,
No, couldn't have asked for better um,
right.
validation of the theory
Yeah,
and validation of the effectiveness of the clinical approach.
right,
So,
right.
but I mean,
Yeah,
it's still preliminary. You know, to become a gold standard treatment, there needs to be studies, similar studies in at least 2 centers. So
okay.
we've just got the one so far.
Okay.
We need other people to do
Okay.
RCTs of DBR and
Okay.
preferably with imaging too.
Right,
Yeah,
absolutely. It's incredible that
yeah,
we were able to get the fMRI and the,
amazing.
yeah, I
Yeah,
saw it. It's huge.
yeah,
It's it's massive that
yeah,
the fMRI machine. It's like it takes up a huge room and
yeah.
quite incredible.
So
And
just,
the mapping of the brain is so
oh, it's
detailed.
amazing. Yeah,
Yeah,
yeah.
yeah, that's
But
exciting.
just like to acknowledge Ruth Lanius and her team here because
Yes,
they've done the study, the clinical
yes,
study, they've done the imaging, they're
yeah,
doing all the analysis now. So
right.
without Ruth Lanius working on this,
Yes.
DBR would be largely neglected, I think. Yeah,
Okay. Okay. Well, yeah, Ruth is incredible and her team is as well. And
yeah,
it's great that you were able to get together and do this work.
Yeah,
Yeah.
yeah,
So, Frank, I wanted to ask you a little bit about a typical session. Because oftentimes clients, when they hear about deep brain reorienting, they're like, oh, is it like meditation and uh, somatic release? That's sort of the frame that they have. So can you describe what a typical session is? Because it is not meditation,
no,
and it certainly there is sensory components to
yeah,
it, but there is a natural release that happens that I think is 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 very different from what people see as a somatic release.
yeah.
So walk us through what a typical session is.
And I think the first thing is that for a talking therapy, there can be not much talking.
Right.
And if people are used to spending a session talking about how they're feeling, they're going to find this very different.
Yeah.
So I think the first thing I usually explain the shock idea to them. So I'll
Yeah.
say the shock would have happened so fast that you would have missed it. You would have gone into the terror quickly because what happened was terrifying.
Right.
But we want to slow this down first to get an anchor in the orienting tension and then to be with the shock.
Mm-hmm.
And I'll explain it as we're going along so that you know what's happening.
Mm-hmm.
So when we get the orienting tension, I'll say that's what it is, and that's an anchor you can go back to if you need to. When we get the shock sensations, I will name them as shock sensations and say these are what we need to be with. So
Right.
not trying to do anything with them, but just be aware of that shiver
Mm-hmm.
down the spine or the pressure behind the eyes or whatever way it
Mm-hmm.
manifests in the person.
Mm-hmm. Mm-hmm.
And that can be hard for people because
Yeah.
the emotions will tend to rush in,
Yeah.
and we have to say, we're going to try to keep these separate. I know
Yeah.
you've got the terror coming in. We want those shock sensations processing separately. So let's do what we can to keep them separate
Yeah.
and and let them process. And somewhere in between, the pain may come through too. So the pain of aloneness or
Mm-hmm.
rejection or humiliation. And again, we're largely sitting with these,
Mm-hmm.
and the the client may feel that strange too, that
Yeah.
we're not doing anything in many people's eyes, but I think we're actually doing a huge amount because we are being with
Yeah.
the person who's got into the core of a traumatic experience, the shock, the pain, the horror,
Right.
and we're helping them identify those sensations and sit with them.
Right. And sometimes we have to work with the client around the discomfort of the silence
Yeah,
because
yeah,
a lot of clients have a hard time with the
yeah,
being with
yeah,
and the quietness of the
yeah,
process, and that's really difficult for therapists who are new to DBR
yeah,
and for clients as well. That there has to be a conversation and a knowing of what's right for each individual client because it's so nuanced, and that attunement may be very different for one client, and like the level of contact with one client may be very different than another client.
and it may even vary from session to session with
Yeah.
the one client with a particular process. The client may want us
Right.
to keep using verbal prompts to
Yes.
register our presence.
Yes.
With another process, they may want to do it in silence because
Right.
us saying anything can feel misattuned.
Yes, absolutely. I thank you for that because you're absolutely right. They can vary from session to session. And I'm just thinking of one client in particular where it's very different from session to
Yeah,
session because the abuse was so extensive and the
yeah,
pain was the pain of being alone and no one being there for
Yeah.
them, and the humiliation was very intense. And
Mm.
so it does vary. And the beautiful thing is clients let you know, like
Yeah. Yeah.
they will say, I need you to talk to me
Yeah.
right now,
Yeah.
or are you with me?
Yeah.
Because some clients want their eyes open, some don't want
Yeah.
their eyes open, so it's very different.
Yeah.
Yeah,
And
yeah,
we're always looking to collaborate
yeah,
and work in the way that the client feels is most beneficial and least likely to be overwhelming. So
right,
we may be talking quite a lot in some situations and totally silent in others,
right.
but still present.
Yeah, for sure.
Yeah.
Absolutely.
Yeah.
And I think that a lot of DBR therapists that are learning, and at times I still ask, and when I'm with clients, the discernment around the slowing down the shock and knowing when you've slowed down enough and cleared enough where it's okay to go to the affect,
Yeah.
because
Yeah.
it can be so interconnected and
Yeah.
intense. And so there's a lot of discernment around that.
Yeah.
Can you speak to that? Because that's
Uh,
a common question that therapists have,
yeah.
is when do I know I've cleared enough shock? Or,
And
yeah,
sometimes it goes into the affect and we move between shock and affect,
right.
shock and affect. But I think the crucial thing is to have named them separately. We've named those sensations as shock.
Yeah,
These sensations are coming from raw emotion.
yeah,
And something about naming them allows the processing in separate
yeah,
channels, I think.
yeah,
And
absolutely.
that way you avoid the additive effect, because if you get the shock plus the affect, then you
Mm-hmm.
can get intense emotion and get overwhelmed. If we separate them out, we're much less likely to
Mm-hmm.
get overwhelmed with the
Mm-hmm.
emotion.
Mm-hmm.
And indeed, often people will be surprised at how easily the emotion processes
Mm-hmm.
once the shock energy is cleared.
Yeah.
It's like the shock's an amplifier that boosts the power of the emotion. And
Mm-hmm.
once the shock's cleared, the emotion's just what it is, and it can
Yeah.
process easily or
Yeah.
more easily.
Yeah. W- Um, I know you know this because I've had the pleasure of doing consultation with you, Frank. But can you speak to how DBR works with OCD? Because one of my clients, I was like delighted at how I was able to treat a client with very severe OCD and get them to the other side.
Yeah,
And I don't think I could have done that with any other modality.
yeah,
And it was absolutely beautiful because
yeah,
the client was close to hospitalization because it
yeah.
was just so significant. And so can you speak to how deep brain reorienting works with OCD? Because I think it's really powerful.
In that case, I remember well from your description, and
Yeah,
the work you did there was great, because that was such a severe disorder,
yeah,
and I don't think
yeah.
we'd have responded to other approaches.
I agree with you. I completely agree with you. So I appreciate how you guided me
Mm.
through that case. But I think the world needs to know
Yeah,
how
yeah,
deep brain reorienting really helps with severe OCD,
yeah,
because this was debilitating for this client. Like there was very minimal daily
yeah.
functioning and close to hospitalization. And so if you could, because I can't say anything else about the case
Indeed,
to honor the
yeah,
client, but if you could
yeah,
speak to that, Frank,
yeah,
I think it's really beneficial for people to know that deep brain reorienting works well with OCD.
yeah. And the imaging evidence on OCD is that in people with OCD, there are upper level loops formed that
Yeah.
would continually have circuitry underneath the ruminations and compulsions and so on. And
Mm.
we argue that if you go to the level below that upper level circuitry, and you deal with the underlying pain and shock and horror and raw emotion, you eventually get the energy out of those upper level circuits. So we treat OCD largely by ignoring the OCD manifestations at the upper level and finding a way to get into the deeper level and work with what's underneath. And as that clears, the energy just goes out of the compulsions and obsessions, and people can get back into a normal way of life. I would love it if somebody would do a study on DBR for OCD,
Absolutely.
because I think you're right.
Yeah.
It's very different approach.
Yeah.
And, you know, if it was studied in treatment-resistant OCD, for example, when other methods have failed, that would be great. It would be really useful.
Yeah, I completely agree. Yeah, absolutely. Absolutely. So another question that often clients ask is, how do I know it's working? Because DBR can be very subtle, because we're looking at the shock responses. And like you said, shock can happen in a millisecond. And sometimes when we find that orienting tension, that anchor, they often go quickly to affect, and we got to slow them down and find that shock. And so it is so subtle, and that's a beautiful thing, because clients don't get overwhelmed by the treatment, which is great. But often clients say, how do I know this is working? And so can you talk to that and the new perspective, and can you say more about that, Frank?
At the end of a session, I never go back to the activating stimulus that we started the session with. And to show that the DBR was working in the session, it would probably be better to do that. But my assumption is that it's working, and it's better instead to say, is there a change in how you see yourself? And that new perspective is often nothing to do with where we started the session. It's often to do with a feeling of having more space, or being more in the body, or having more strength or courage or something of that sort. And that's what we invite the person to focus on after the session. Sometimes people will not get a new perspective and not say, I don't think anything's really happened, but they report week by week other changes in their life that indicate progress is being made here.
Right, absolutely. And a lot of times the new perspective is, like you said, it's very sensory based. It's that feeling my body is different. There's more space, or I'm not as tense, or I feel like I can hold my head up, or I actually feel solid. It's usually a sensory reporting, like a somatic reporting.
And gradually there's an increase in embodiment for many people, and it just happens with the continuing processing, the sense of owning their own body, which may be completely new to them.
That's so powerful. They own their own body. And they connect with the aliveness. Because sometimes we do the proto-self, which helps them deepen into the sense that they're in a body that's alive. But when we don't do the proto-self and we just do the aware-self, that can come up in the new perspective as well.
The energy, the freedom's another word.
It's so exciting when you hear what clients say when they share the new perspective, because it is drastically different. How they experience their body and, in essence, themselves is very different from where we start the session, or where we've started the work from. Pretty incredible. And spending time leaning into it, rather than just quickly doing the new perspective, is actually spending some time where the clients can absorb it a bit.
It's good if there is time in the session to be able to sit with that change.
Hmm.
and give it a chance to just be and,
Yeah,
you know,
yeah,
helps
absolutely.
it to become more long term.
Yes,
Yeah.
absolutely. So I have a big question to end things off,
Hmm.
Frank. So if DBR were widely adopted, and how would you imagine it could change the landscape of trauma therapy worldwide?
My hope is that it would help to prevent PTSD if it
Mm,
were applied early enough.
yeah.
For example, when I've worked in areas that are undergoing shelling, for example, somebody can be immobilized
Yeah.
as a result of the building nearby being shelled. So the shock is held in the body, and if they're able to come for a session and we clear the shock, then they're more able to engage their natural defenses and be able to
Mhm.
go to shelter when the alarm sounds and so on. I hope that those people who are processing the shock the day after or as
Mhm.
very soon after are going to then be at less risk of PTSD long term. So I
Right.
think if we could get DBR in quickly in
Yes.
areas where people are being traumatized
Yeah.
and help to clear the shock of the
Mhm.
trauma, I hope we would reduce the risk of PTSD, and that really needs a study too.
Yeah, right, right.
Yeah,
Lots of studies need to
yeah,
occur.
yeah,
But yeah, that I totally agree with you,
yeah,
and that would be absolutely beautiful
yeah,
if we had reduced experiences of PTSD and complex PTSD if we can get in early,
yeah,
especially with kids,
yeah,
right?
yeah,
Kids and adolescents, if we
yeah,
could get in early, because they're exposed to a heck of a lot,
yeah,
and so that would be good. And it reminds me of a case where I got in. I was able to do DBR a week after a traumatic event for someone, and we did two DBR sessions, and no PTSD symptoms
yeah,
afterwards.
yeah,
And it was a very horrifying
yeah,
experience for this person. And at the end of the first session, I think I shared this with you, Frank. At the end of the first session, he started to cry and said, "I feel like myself again."
yeah,
And I never
yeah,
thought I would feel like myself
yeah,
after what had happened to him,
mm-hmm,
which was like he was he was crying because, with relief
yeah,
and joy, and when you see that kind of difference with clients,
mm-hmm.
it wow, it touches you as
It's
well.
very moving.
Yeah.
Yeah, mm-hmm.
Yeah. Well, thank you so much for spending the time with us and for bringing this amazing modality into the world and for continuing to build it and refine it and share your incredible ideas with us.
You're very welcome. Thank you for the invitation.